Move over to our next star of the meeting, Dr. Vivek Subbiah, to introduce Vivek, to welcome Vivek, I bring in money, and to introduce Vivek, I bring in my good friend, Dr. Nitesh Rohatgi, who is at Max Hospital, Delhi, and he trained at London, he worked at London Oncology, the great London Oncology Clinic, and is a star medical oncologist here in India. So with that, I go over to Mani, and Mani will then hand over to Nitesh. Thank you so much, everyone, and thank you for the great session. And we go on to the next segment. Thank you.
Thanks, everyone. It's a spectacular, it's a mind-blowing learning experience. And thanks to again, Ray and the previous panelist, Nirma, and everyone. Thank you all. Now, it gives me a great pleasure to introduce our next speaker, Dr. Vivek Subbiah, who is a very good friend and an amazing scientist. The world is too small. In fact, Vivek was recruited to MD Anderson by Ray. The phase 1 clinic, Vivek is the one who's running the majority of the clinical aspect of the phase 1 clinical trial at MD Anderson. So, even though we work at the same institute, we hardly get to see each other because MD Anderson is a huge place. So when we were going to Chennai for a meeting which was organized by Raja, Dr. T. Raja, we got a chance to interact more. And on the plane, as well as when we in Chennai, we went for a run along the beach, and we got to interact more and learn what he's interested in, what we are interested in. And since then, we have been working a lot more closely. He's a wonderful friend, and he's passionate about helping cancer patients. I think that's what connecting all of us who are in this panel together is, that not just forming a company, make money. No, that's not at all his mission of even forming an Iylon. It's purely the passion to help cancer patients who are going through tough time, and then how we can just give a small part of our support to help them to overcome or to beat the disease. That's all is the goal. With that, Vivek has been kind, and he has been giving so much advice since he joined as an advisor even before to Iylon. He's got a magnetic personality, and he has an infectious smile. He's always with a smile. Anytime you ask him for any help, he never hesitates to come out and help. Recently, Vivek and we even started even to study the tumor evolution at a single cell level, right? When a tumor is bulk and you give a treatment, 80% tumor gone, 30% tumor gone, some tumor cells left. And we are trying to investigate what was there in the beginning, what is there later at a single cell level to see whether we can identify vulnerabilities. And he's a wonderful colleague, again, a good friend. And without further ado, I pass the mic to Dr.
That's a tough one. Mani. That's Dr. Rohatgi.
I tried my best.
Thank you very much. You did. And you are right. When I was at MD Anderson for a few months with Chris Logger's thesis and Eric Yonash, it's a jungle. It's a concrete jungle. You can't find your way back to where you left. On talking about Vivek, it's really an honor to introduce a personality like himself. He's an associate professor in investigational cancer therapeutics, and we all know how difficult and yet most critical is the phase 1 program, which he heads. And this is obviously at the Center of Clinical Medicine at the Targeted Therapy at the MD Anderson itself. Dr. Subbiah is a major advocate of precision oncology. He's a national leadership role that is to continue the expansion of and he's a principal investigator of the BRAF non-V600, and that's important, BRAF non-V600 alteration in the NCI match precision medicine clinical team. And we all know how these small precisions and investigations have led to such a big change as we sit in 2021, talk about in a molecular board, but they all started with small research. Dr. Subbiah has unique training background as he is one of the few physicians in the nation, maybe the world, to have been trained in oncology, both in adults and in children. I think kudos to you for actually doing that much in such young age. A clinical trialist and physician investigator at the Department of Investigational Research and Therapeutics at MD Anderson, which we know is one of the world's biggest and largest oncology drug development units. He is primarily involved with translational cancer research and the design and conduct early phase clinical biomarker driven clinical trials. A specialist interest is in antibody drug conjugate, and we've seen how that changed the world in the last 2 3 years, with with a special interest in radiopharmaceuticals and immunoconjugate as well as the basket trials. So over to Dr. Subbiah for his talk, a long-awaited one.
Good morning, all. Thank you for the wonderful opportunity for me to present challenging standard of care paradigms for rare cancers, the story of BRAF and RET. In my brief agenda for today, I will be talking about the definitions of precision oncology and personalized medicine, and also talking about clinical translation, specifically touching down upon basket studies and my brief experience with BRAF inhibitors and RET inhibitors. How did we treat advanced and metastatic rare cancer before the sequencing era? This is how we treated them. What is personalized medicine or precision oncology? Treatment is precisely customized to the characteristic of each individual's tumor and host. This includes immunotherapies and genomically targeted therapies. In the oncology world, this is called precision medicine or precision oncology, and in non-oncology fields, this is called personalized medicine. So what is personalized cancer medicine? In the current practice, we treat one treatment for the average patient in a basis of trial and error method. With personalized medicine, the right treatment is given for the right patient at the right time at the right clinic. The personalized medicine can answer these questions. What is the specific subtype of disease? What is the best treatment? What is the likely outcome if the patient is given that treatment? Can side effects be avoided? Can the condition be predicted and preventive measures taken? The management of a patient's disease or disease predisposition and the administration of therapies that convey maximum effectiveness and safety given the patient's unique genetic and molecular profile is utilized in personalized medicine. Here you can see the response rate in selected early phase clinical trials with targeted therapies when using molecular matching. Of course, imatinib is the poster child of precision oncology, which started with BCR-ABL fusion positive CML with response rates as high as 77%. Most recently, we had BRAF inhibitors active in multiple tumor types, like the vemurafenib active in melanoma with a response rate of over 70%, and dabrafenib and trametinib, BRAF and MEK combination, active in multiple diseases with response rates over 50%, and most recently, NTRK fusion across all cancers, and selpercatinib and pralsetinib as RET inhibitors active in both RET mutant and RET fusion positive patients. Then we have immunotherapy. Immunotherapy recognizes a mutanol. What are the biomarkers of immunotherapy response? I think this is an active area of research. We have mismatched gene defects in colorectal cancer and other cancers. And most recently, we have high tumor mutational burden emerge as a biomarker in multiple cancers. In addition to these, we also see molecular anomalies such as PD-L1 amplification in Hodgkin's disease and other diseases. So how does cancer immunotherapy compare with traditional therapies? Again, traditional cancer therapies can target both normal and healthy cells, whereas cancer immunotherapy, by unleashing the patient's own body defenses, the patient's own immune system, it can selectively target the cancer cells with few to no side effects. So we have immunotherapy, a lot of targets from immunotherapy: PD-L1, PD-1, CTLA-4, ICOS, VISTA, LAG-3, TIGIT, more and more targets coming in immunotherapy space. And we have a lot of small molecules and monoclonal antibodies, which are high priority targets for targeted therapy. Again, the future is combining chemotherapy, targeted therapy, immunotherapy, radiation oncology, and surgery to offer the personalized medicine to the right patient at the right time. In the next set of slides, I'm going to share some experience about precision oncology, talking about basket studies in oncology and my experience with the BRAF inhibitor monotherapy study, also known as the WEM basket study, and the BRAF inhibitor combination therapy, the ROAR study, the rare oncology agnostic research study, and my experience with RET inhibitors in the recent past. So what are umbrella trials and basket studies? A basket study enrolls patients who have the same genetic mutation, whether their cancer originated in the lung, breast, colon, liver, or any organ. These are histology independent studies. Then has the patient received the same novel treatment that targets a specific biomarker? This strategy highlights a different way of thinking about cancers, not based on the tissue of origin and where they originated, but rather based on the mutations that drive these cancers. An umbrella trial is one type of cancer with different genetic mutations where patients are enrolled on multiple different drugs. So again, you get the gist. So this is a basket study. A patient with mutation A will go on a basket, a patient with mutation B goes on another basket, and a patient with mutation C goes on a third basket. To give you a specific example of a basket study, the first iteration of a basket study was a BRAF basket study. Why BRAF? BRAF oncogene is seen in 5 to 10% of all human malignancies. It's a most common tumor that expresses BRAF, or rare or ultra-rare cancers. It leads to constitutive activation of the MAP kinase pathway. And the most common mutation of the BRAF is the valine to glutamic acid substitution at codon 16, the V600E mutation. BRAF V600 is a driver mutation in multiple solid tumors, such as colorectal cancer, papillary thyroid cancer, non-small cell lung cancer, anaplastic thyroid cancer, GIST, etc. It's also a driver mutation in multiple hematological malignancies, including Langerhans cell histiocytosis, Erdheim-Chester disease, hairy cell leukemia, and even multiple myeloma. In one of the first iterations of a basket study, in a histology-independent design, we designed a basket study with multiple cohorts wherein any patient who harbors a BRAF V600 alteration receives vemurafenib 900 milligrams orally twice daily. Based on the tumor type, they go on different baskets. A non-small cell lung cancer patient with a BRAF V600E mutation would go in that basket, and a cholangiocarcinoma patient would go in another basket. Initially, we saw in non-small cell lung cancer, the response rate was 42%. Interestingly, in Erdheim-Chester disease or Langerhans cell histiocytosis, the response rate was 43%. And this led to an FDA approval based on this basket study. In addition to this, we saw responses in rare tumors like pleomorphic xanthoastrocytoma, anaplastic thyroid cancer, cholangiocarcinoma, salivary duct cancer, ovarian cancer, and clear cell sarcoma. Interestingly, at the same time when this trial was ongoing, the world realized that vemurafenib alone was unresponsive in patients with colorectal cancer. And at that time, there was a Nature Medicine paper that was published showing that EGFR was an innate mechanism of resistance to BRAF inhibition in colorectal cancer patients. So at that time, when the study was ongoing, another arm was added with an EGFR monoclonal antibody, cetuximab, and among patients with colorectal cancer were enrolled on that arm. So this validated BRAF V600 as a therapeutic target beyond melanoma and led to tumor agnostic sensitivity of vemurafenib with the exception of colorectal cancer. And again, BRAF as a therapeutic target was established in multiple tumor types, as you can see here. The final analysis shows pan-cancer efficacy of vemurafenib in BRAF V600 mutant non-melanoma cancers. Again, science moved on. The BRAF and MAP kinase combination was developed and was approved in melanoma. Why the BRAF and MEK combination? This leads to sustained target inhibition to observe more prolonged and durable anti-tumor effect. The combination delayed and potentially prevented development of resistance. In addition, interestingly, hyperproliferative skin lesions and secondary malignancies are common with monotherapy BRAF inhibition. So the combination prevented or delayed these hyperproliferative lesions and secondary malignancies. So because the science moved, a clinical trial called ROAR, the Rare Oncology Agnostic Research, was designed. Again, the concept was similar to VEM basket design. Several buckets or baskets of patients were enrolled with advanced disease with no treatment options as long as the patient's tumor harbored a BRAF V600E alteration. Herein, the patients received dabrafenib, the BRAF V600 inhibitor, and trametinib, the MAP kinase MEK inhibitor, until progressive disease or unacceptable toxicity. The primary endpoint was investigator-assessed objective response rate. Secondary endpoints included duration of response, progression-free survival, among others. Again, early in this study, we saw fantastic responses in anaplastic thyroid cancer. Anaplastic thyroid cancer, as you may know, is one of the most lethal diseases known to man. And there was no other agent approved in this setting. In this anaplastic thyroid cancer patients who harbored a BRAF V600E alteration, the preliminary objective response rate was 69%. And you can see the promising responses in just 8 weeks of therapy on this treatment. Based on this data, FDA approved dabrafenib and trametinib in BRAF positive anaplastic thyroid cancer. So we saw early successes with these basket studies in precision oncology, be it vemurafenib in hereditary disease and Langerhans histiocytosis, or dabrafenib and trametinib in anaplastic thyroid cancer. In fact, the ROAR trial continues, and most recently, the data from the ROAR study was published in Lancet Oncology that showed an investigator-assessed objective response rate of 51% in BRAF V600E mutated biliary tract cancer. Again, what it showed that the clinical benefit of dabrafenib and trametinib supports the use of this combination as a treatment option in patients with BRAF V600E mutated biliary tract cancer. This led to inclusion of this regimen in the NCCN guidelines, and we recommend routine testing of BRAF V600E mutations in all patients with biliary tract cancer. Switching gears to RET inhibitors. In this set of slides, I will be discussing about RET aberrations in oncology, RET alterations in non-small cell lung cancer, RET alterations in medullary thyroid cancer and multiple other cancers, and what we had in RET inhibitors with multi-kinase drugs, and the advent of selective RET inhibitors, selpercatinib and pralsetinib. RET is a receptor tyrosine kinase that is required for normal development. Alterations in RET structure and function can lead to tumorigenesis. RET can be activated by two major mechanisms. One is mutation and one is fusion. Oncogenic RET alterations have been identified in numerous cancers. In fact, RET is one of the first oncogenic kinase fusions cloned from an epithelial tumor and has since been found to be an oncogenic driver primarily in multiple solid tumors. It was identified as an oncogene in 1985, and it was identified as a fusion in papillary thyroid cancer in 1990. Only in 2012, it was discovered that RET fusions are present in lung adenocarcinoma. And 2017, we had the advent of selective RET inhibitors in first-in-human clinical trials. And recently, they were FDA approved. I'm going to share a few slides on how these drugs were developed. RET is activated by two major mechanisms in cancer. One is a RET fusion, and the other is a RET mutation. RET fusions are known oncogenic drivers in 2% of lung cancer and 10 to 20% of papillary and other thyroid cancers. It is also seen in multiple other neoplasms like pancreatic cancer, colorectal cancer, myeloproliferative disorders, albeit less than 1%. In medullary thyroid cancer, it is seen in 100% of patients with hereditary medullary thyroid cancer and over 60% of patients with sporadic thyroid cancer. A number of oncogenic RET fusions and activating point mutations have been identified to date. The most common RET fusion partners in non-small cell lung cancer are KIF5B, the CCDC6, and the NCOA4. In papillary thyroid cancer, the most common RET fusion partners are CCD6, the NCOA4. What are the activating point mutations? The most common activating RET mutations in medullary thyroid cancer are the M918T. In addition, the C series, the C634F, G, R, S, W, and Y. In addition to a gatekeeper mutation called V804M. The challenge was we didn't have selective RET inhibitors in the couple of decades ago, or even in this decade, early in this decade. We had several multi-kinase inhibitors, like all the small molecules inhibitors, the multi-kinases, like cabozantinib, pandatinib, lenvatinib, sorafenib, sunitinib, dovitinib, motacinib. So many multi-kinase inhibitors have a greater potency on several off-target kinases across the kinome, such as the VEGFR2. The potential toxicities from multi-kinase inhibitors from off-target toxicities include hypertension, hand-foot syndrome, proteinuria, hypopigmentation, QT prolongation, thrombosis, and hemorrhage. So the results from several studies of multi-kinase inhibitors in non-small cell lung cancer and thyroid cancer demonstrate a high rate of dose reduction and drug discontinuation. So we were essentially in need of superheroes for RET inhibition. So how do we define a superhero? Patients with RET-altered non-small cell lung cancer did not achieve the promise of precision therapy before 2020. So the objective response rate achieved with multiple kinases with RET patients were in the order of 6 months in non-small cell lung cancer. But you can see patients with osimertinib or ALK-rearranged cancers, patients had a PFS of 18 months. So patients with RET-altered non-small cell lung cancer have not yet achieved the promise of precision therapy before 2020. Enter selpercatinib. After confirming high kinome selectivity, as seen in this kinome dendrogram, and preclinical activity across multiple RET fusion and RET mutation models, it was also shown that this drug was active in the brain as well in preclinical models. In one of the first ever patients to get access to selpercatinib, I'd like to describe a patient of mine here. This was a 49-year-old man with a history of advanced medullary thyroid cancer with RET M918T mutation. This patient had progressive disease after receiving 6 multi-kinase inhibitors over 7 years. This included sorafenib, vandatinib, cabozantinib, a couple of experimental therapies, combination of multi-kinase inhibitor, vandatinib, in combination with mTOR inhibitor everolimus. And at that time, we found that this patient's tumor had an acquired gatekeeper mutation in addition to the M918T mutation. We knew from the preclinical data that selpercatinib or LOXO-292 covered this gatekeeper alteration. This patient was treated by a compassionate single patient IND with an intra-patient dose escalation. Within a couple of weeks after starting treatment, there was complete resolution of diarrhea. Before starting treatment, the patient's performance status was rapidly declining with over 30 bowel movements a day and pain from a huge liver mass. The pain resolved within the first 2 weeks. The calcitonin precipitously dropped with a concurrent reduction in tumor size by 54% per RECIST. The patient remained on treatment for over 2 years with grade 1 side effects. Again, as you can see, there was a dramatic decline in the tumor markers, calcitonin and CA, with concurrent decrease in the RET cell-free DNA mutants. This shows the RECIST response in this patient and the massive tumor burden that the patient presented with before starting on therapy. At the same time, blood-brain barrier penetration was also demonstrated in a patient with non-small cell lung cancer, again, who had progressed from chemotherapy and immunotherapy. In parallel, concurrently, the Libretto 001 trial was designed, and this was a phase 1 dose escalation design. And so eligibility consisted of patients over 12 years of age with an ECOG performance status of 0 to 2. Patients could have received any number of prior therapies. Again, RET alteration was not initially required, although it was added by adequate PK. And CNS metastasis with stable symptoms were allowed. It followed a 3+3 design, and the recommended phase 2 dose was defined as 160 milligram orally twice daily. This was published in August 2020 in the New England Journal of Medicine, and this was noted to be one of the most important or notable articles of 2020. So what did this phase 1 clinical trial show? In the primary analysis set of lung cancer patients, this consisted of 105 patients, were the first 105 patients who received prior platinum therapy. Among the 105 patients who were treatment refractory, and there was another cohort of patients who were treatment naive as well, a total of 39 patients. The most common RET fusion partner was HIF5B, followed by CCD6 in both the cohorts. Selpercatinib was efficacious regardless of prior chemotherapy, regardless of prior immune checkpoint therapy, and regardless of receipt of prior multikinase therapy. In the primary analysis set, consisting of 105 patients, the objective response rate was 68%. And in the treatment naive cohort, the objective response rate was 85%. This shows the duration of response and the progression-free survival in the primary analysis set. And this shows the duration of selpercatinib efficacy in the treatment naive cohort. This shows selpercatinib activity in a patient in the treatment naive setting. And you can see beautiful before and after striking responses in this patient, showing brisk, durable, confirmed PR by RECIST 1.1. Selpercatinib also overcome acquired gatekeeper resistance, as seen in this patient from Japan, a 42-year-old female who had 15 prior systemic therapy regimens with an acquired V804L gatekeeper post-vandatinib therapy. So based on this data, and this showed that selpercatinib was efficacious in RET fusion positive non-small cell lung cancer. In previous platinum-based chemotherapy patients, the response rate was 64%. And in the previous untreated patient population, the response rate was 85%. Based on this data and the data in medullary thyroid cancer patients and papillary thyroid and other thyroid RET fusion positive patients, selpercatinib was approved by the US FDA for the treatment of RET fusion positive non-small cell lung cancer, RET mutant medullary thyroid cancer, and RET fusion positive all thyroid cancers. And this was a line agnostic approval. Moving on to talking about pralsetinib, Blue 667, which is also a highly potent and selective RET inhibitor. After showing high kinome selectivity for RET, it was shown that this drug, the Blue 667, also known as pralsetinib, was more potent and selective than the available multi-kinase drugs. Pralsetinib potently inhibits the most common oncogenic RET alterations found in diverse tumor types. It inhibits the RET M918T activating mutation in addition to the gatekeeper mutation while sparing the VEGF-R2 domains. As seen in this kinome dendrogram, Blue 667 or pralsetinib was designed to treat RET-altered cancers. The ARROW, the first in human study, was designed with pralsetinib, and it showed a dose-dependent exposure and RET pathway inhibition. And the PD pharmacodynamics showed RET pathway inhibition with MEK-ERK dual phosphatase 6 and SPRODY4 mRNA inhibition. Interestingly, it showed dose-dependent decline in medullary thyroid cancer tumor markers, the carcinoembryonic antigen and calcitonin. This was one of the first patients to be enrolled in the ARROW pralsetinib clinical trial. This was a patient of mine, a young man who was a 27-year-old male who had a large neck mass, and he had an emergent tracheostomy done. And because his tumor invaded the trachea, esophagus, and the major vessels, multi-kinase inhibitors were a relative contraindication. And radiation therapy would cause fistula formation. So we started the patient at a low dose level with the selective RET inhibitor. And it was initiated at 60 milligrams and slowly was dose escalated. The patient is still on treatment after 3 years on therapy. It is so rewarding for us to see such young patients benefit from targeted therapy and can go back to living a normal life. Similarly, another young adolescent and young adult female also benefited from pralsetinib therapy. Again, this trial continued to a phase 2 dose expansion cohort at 400 milligram once daily dosing cohort. The primary endpoint of the phase 2 trial was objective response rate, and key secondary endpoints included duration of response and disease control rate, among others. 132 patients with lung cancer were enrolled, 92 patients with prior platinum therapy, and 29 patients who were treatment naive. Again, the response rate in the treatment naive cohort was 66%, and in the response evaluable population, in the treatment naive cohort, the response rate was 73%. And in the prior platinum cohort, the response rate was 61%. The median duration of response was not reached by blinded independent central review. As you can see in this waterfall plot, 96% of evaluable patients had tumor reductions, and 100% of treatment-naive patients had tumor reductions. This included 6% complete responses in evaluable patients and 12% complete response rate in treatment-naive patients. In addition, in medullary thyroid cancer, who had RET mutation with prior cabozantinib or vandatinib, had an overall objective response rate of 60%, And in RET mutated medullary thyroid cancer patients with no prior systemic therapy, the objective response rate was 74%. The pralsetinib study continued, and beyond non-small cell lung cancer and medullary thyroid cancer, it also accrued another cohort with RET fusion positive other tumors. Again, Arrow study also showed that pralsetinib was active in the central nervous system. And you can see the before and after images showing intracranial activity of pralsetinib in this 56-year-old female never smoker. And this shows the baseline characteristics of RET fusion positive thyroid cancer patients and RET fusion positive all solid tumors. Among the tumor types enrolled, patients had colon cancer, pancreatic cancer, colorectal cancer. And among the RET fusion positive thyroid cancer patients, there were papillary thyroid cancer patient and polydifferentiated thyroid cancer patient enrolled. This shows activity of pralsetinib in RET fusion positive thyroid cancers. And you can see that almost all patients had tumor shrinkage with an objective response rate of 91%, a partial response rate of 91%. And pralsetinib was active regardless of the tumor type and regardless of the RET fusion partner. This shows that pralsetinib is very active with rapid responses, and the swim plot shows the duration of response in these patients with multiple types of thyroid cancer. This shows the activity of pralsetinib in various RET fusion positive solid tumors. Responses were observed in all patients with pancreatic adenocarcinoma and cholangiocarcinoma. Here in the objective response rate was 50% with a partial response rate of 50%. Interestingly, the disease control rate here was 92% among various RET fusion positive solid tumors. The response duration was also seen in the slide set. It showed brisk, quick responses in patients. Based on all this data, pralsetinib is now approved for the treatment of RET positive non-small cell lung cancer and RET positive thyroid cancer. Again, this is also a line agnostic approval. The Libretto 001 and the Arrow trials show potent RET pathway inhibition with favorable tolerability. They showed broad anti-tumor activity regardless of RET genotype. They showed high response rate and durable activity. The dose escalation and expansion data validate selective RET inhibition as a promising therapy for RET-altered cancers. Now, these agents are FDA approved. The superheroes have arrived. The FDA approval, which was unheard in oncology before these inhibitors and before the advent of small molecule inhibitors. The timeline of drug development from first in human to phase 1 was approximately 3 years. I think we can do better. I think given the COVID time and COVID-19 vaccine, we were able to get these vaccine up and ready within a year for emergency use authorization. I think we should apply the same principles to oncology. So what's next in RET? Acquired resistance mechanisms. We recently reported the structural basis of acquired resistance to selpercatinib and pralsetinib, that it is mediated by non-gatekeeper RET mutation. Again, resistant to selpercatinib and pralsetinib are found at the solvent front and hinge sites of the RET kinase domain mutation. I'm sure you remember the patient, the first ever patient that went on the selpercatinib on compassionate access, who progressed on 6 prior multi-kinases. This patient was on selpercatinib therapy for quite a long time and developed the solvent front G10C, G10S mutation. And this shows that selpercatinib and pralsetinib use an unprecedented binding mode to dock into RET kinase. The identified selpercatinib resistant mutants are cross-resistant to pralsetinib as well. So we are really looking forward for the second generation of RET inhibitors that can cover these non-gatekeeper RET mutations. So what do we need in precision oncology? I think we need to have a molecular barcode, a portrait of every patient walking into the clinic. A thought for the day before I finish my talk is that the light microscope invented in 1590 is still used to diagnose and classify cancer. Universal genomic testing is needed to win the war against cancer. Is there enough benefit to justify sequencing all patients' tumors? Yes. A fundamental premise of oncology, indeed all of medicine, is that every disease, even an untreatable one, warrants a diagnosis. Genomics is a diagnosis. You may all know the story of 6 blind men and the elephants. So I just spoke about genomics. The future is about getting the molecular portrait of the whole cancer, of the whole patient. That includes metabolomics, transcriptomics, immunogenomics, microbiomics, and proteomics. Panomic testing is a requisite of comprehensive analysis and may require complex computer algorithms for data integration and computation. In 2020, the death rate from cancer in the US declined by 29% from 1991 to 2017, including a 2.2% drop from 2016 to 2017. The decline in deaths from lung cancer drove the record drop. Deaths fell from about 3 per year from 2008 to 2013 to 5% from 2013 to 2017 in men and 2% to almost 4% in women. This was mainly driven, I feel, by precision oncology and better screening methods. We all live in the COVID era. The COVID has burdened our lives. How do we overcome this? And how do we restore the balance of cancer care, of precision oncology and personalized medicine care in the COVID era? We look forward for the future for this with the availability of vaccines and personal protective equipment. The COVID pandemic also has forced all of us to rethink clinical trial designs, to find the silver lining from clinical trials being designed clinical trial centric to clinical trial being designed patient centric. I think hopefully this is one of the silver linings of the COVID pandemic, that precision oncology studies would be designed from being clinical trial centric to patient centric, so that the right treatment for the right patient at the right time can be delivered in the right place, which is closer to their home. In conclusion, I'd like to thank all the patients and their motivated families who enrolled on all these clinical trials. I thank the investigators and staff at MD Anderson Cancer Center and worldwide collaborating sites for all the clinical trials. And please feel free to contact me. I'm in Twitter. This is my Twitter handle. And thank you so much for the wonderful opportunity.
That was a wonderful, wonderful talk. I turn over to Nitesh to field some questions before we move over to the molecular tumor board.
No, I have less questions. I have more admiration. Very rarely do we hear a talk like that, which is basic science and so stimulating. I'm looking at Ullas and wondering why is he not doing that kind of work, because truly I believe he's the only one in India who has that capacity to build up basic science work. But really looking forward to the tumor board, and my kudos to both the team and Dr. Subbiah and Toto. Thank you.